feel it's quite a simple one, the entity, but after going through literature, looks to be very complex for me at least, because so many anatomical, physiological, and then pathological changes are occurring in the short gut syndrome, and then management is very problematic, both for the medical gastroenterologist as well as for the surgical gastro. So that's why I've chosen this topic. Now I'll be talking on this headings like anatomy, physiology, definition, pathophysiology, the classification, clinical presentation, how do we work up, and then a few words about the treatment part. Now, if you go to the anatomy, as Dr. Dheeraj was saying, we have about 600 centimeters of intestine in the normal adult. But in the neonate, it's only about 250 centimeters. Now, when you call a short gut, that means gut has become small because of so many factors. It could be a structural reduction in size or the functional reduction in size. So when it comes to about 200 centimeters in an adult, from 600 to 200 centimeters, or average, if you take more than 50 to 80% of the intestine is lost, then we call this a short gut syndrome. And then these people are on TPN, there's parenteral nutrition, and the length which is required for the normal survival of this short gut people, it depends on the presence of colon or without a colon. If the patient is having the colon retained, then 60 centimeters of the small bowel is sufficient for survival. And without a colon, we need about 100 centimeters of the small intestine. With infants, it depends on the presence of ileocecal valve, and then apart from the colon also. Now, if you go into this, the physiology of normal the absorption and the digestion, the jejunum and the ileum. This is jejunum, this is the ileum. Here the villi in the jejunum are very long, wherein the ileum is quite very short. The absorbed surface is large in the jejunum and it's less in the ileum. The tight junctions, which are the normal junctions present between the intercellular surfaces, they are quite large in the jejunum, whereas they are tighter in the intestine, in the ileum. Here the epithelium is more porous to the larger molecules. There's free and rapid flux of water and electrolytes in the jejunum. Whereas in the ileum, it permits less flux of water and electrolytes from the vascular surface into the intestinal lumen. Water absorption in the jejunum is less effective, whereas it's more efficient and effective in the ileum. Absorption of carbohydrates, proteins, fats, vitamins, and are more in the jejunum, and bile acids and vitamin B12 absorption is more in the ileum. And again, we have a lot of GI hormones which affect the intestinal motility. Especially the ileum is more important for that, where we have enteroglycan and peptide Y hormones. Now, if you compare the jejunum and the ileum, see, the jejunum resection is better tolerated compared to the ileal resection. Why? What's the reason? Because ileum is the main thing which is absorption because of this vitamins and other things. So here, this is in this jejunum, suppose the resection is there, the absorption is compensable. There's a compensating increase in the absorption capacity because the ileum is there left over. So at least from jejunum, if it's not absorbed, it goes to the ileum and gets absorbed. At least part of it, if not the total. Whereas if the ileum is resected, 90% of the jejunum is proximal. So, so here, because of the taller villi, deeper crypts, and greater enzyme activity of the jejunum, it is relatively less affected. And in uncompensated digestion in jejunal resection happens, and there's a loss of biliary and pancreatic secretions. There's a high gastrin as a result of jejunal resection, which leads to mucosal damage, inactivation of the pancreatic enzymes. Whereas in the ileal resection, what happens is, the beta malabsorption, there's bile salts accumulation in the fat malabsorption, steatorrhea, and loss of fat soluble vitamins. And both the jejunal and the ileal will have a diarrhea. So how do you make out? Due to the large osmotically active solute load of the undigested nutrients delivered into the ileum and colon, this is the main cause for diarrhea. Whereas in the small ileum resection, because of the presence of bile salts, these are mainly the secondary bile acids also get increased in the ileum, and then this blocks the water in the electrolyte absorption from the ileum, and then leads to bile acid diarrhea. Now, because the intact ileum is there in this what you call the jejunal section, the intestine time can be improved, whereas in here, it's very fast. So by now we can define, after seeing all this, the normal absorptive mechanisms and the physiology of the bowel, it can be defined as a malabsorption, presence of diarrhea, presence of steatorrhea, fluid and electrolyte imbalance, and malnutrition, and more than 50% of the bowel is affected. It could be a structural, that is surgical removal, or a functional loss. This is we should not forget of the functional loss, because as medical gastro we come across these things. Surgical gastro come for the structural defects. So ultimately, management comes to the medical gastro. So what's the cause of functional loss of small bowel? Though the full length of the intestine is maintained, so that will come a little later. So the short bowel can be because of underlying disease, because of extensive bowel resection, and which can affect the normal intestinal physiology, alteration in the intestinal absorption and digestion, and then leads to nutritional, metabolic, and infective complications. Now, presence of ileocecal valve is very vital. It's paramount, because loss of ileocecal valve leads to a lot of other problems. We'll come to that. When the ileocecal valve is removed because of this resection, the transit time is faster because it's rapidly emptying from the ileum to the colon, and the loss of fluid and nutrients is much greater. And what happens, because of the loss of the IC valve, the colonic bacteria goes back into the small bowel, a reflux of the bowel. See, actually, the small bowel bacteria, microflora, and the large bowel flora are totally different. So there'll be mixing of the large bowel into the small bowel microflora. And this causes a lot of other problems and leads to worsening of the diarrhea and nutrient loss. So this presence of ileocecal valve is very important if you try to preserve that during surgical resection. Now, when we have to preserve the colon, so there's always some amount of benefit if the colon is preserved. Here, the colonic water absorption could be increased as much as 5 times its normal capacity. Whereas if the colon is, the demerits of preserving the colon are increase in the incidence of urinary calcium and oxalate stone formation. This is because of the increased presence of oxalate, it's combined with the calcium and then leads to the oxaluria and urinary oxalate stones. And when after massive enterectomy, this calcium, is bound by free intraluminal fats. Now, by preserving the colon, what happens? I told you, colonic bacteria. They metabolize undigested carbohydrates into short-chain fatty acids such as butyrate, propionate, and acetate. Whereas, if the colon is removed, small intestinal bacteria overgrowth occurs in the absence of the ileocecal valve. So there's a lot of interplay depending on the presence of colon, presence of IC valve, removal of the IC valve. So, how a patient presents with the shortcut, we have 3 phases in it: acute phase, adaptation phase, and the maintenance phase. I'll be talking a little detail about the acute phase. It starts immediately after the bowel resection and lasts for about 1 to 4 months after the surgical procedure. So this is very important because during this time, there are a lot of electrolyte imbalance, dehydration can occur. So the ostomy output can increase about 5 liters per day, leading to dehydration and electrolyte imbalance. So we have to tackle this and be very alert in the acute. There's 1 to 4 months of the resection. And there's extremely poor absorption of all the nutrients because everything is coming out as diarrhea. And there's a development as a composite increase in the hypergastrin. The gastrinemia also occurs, and there'll be increase in the risk of hyperbilirubinemia in this acute phase. Now, once the acute phase is tided over, then we come to the adaptation phase. Here, what happens, the existing bowel, the remnant bowel, what is there in the body, there'll be changes and adapting, and then morphology also changes. Here, there will be enterocyte hyperplasia. It's a composite mechanism. Such we know about when the one lung is removed, the other lung gets composite emphysema. So that way, enterocyte hyperplasia. One kidney is little small, the other kidney compensates a relative renal hypertrophy. Enterocytes also have a tendency to have a hyperplasia of the enterocyte. Villus hyperplasia can also occur. The depths also will keep increasing so as to increase the surface area for absorption. So this is a nature's mechanism for the remaining bowel to adapt itself. You can imagine there will be intestinal dilatation and lengthening. See the amount of the centimeters which I told, the increase in length also. So that's the nature's preventive mechanism for improving the composition for that. There will be increase in the capacity. There will be low transit time in the bowel movements. So this adaptation phase starts within 48 hours of resection. So it is an overlap of adaptation phase with the initial acute phase. And it can last up to 1 to 2 years. Whereas 1 to 3 months or 4 months is the acute phase. This occurs from 1 to 2, up to 1 to 2 years also, from 48 hours. So adaptation starts from 48 hours up to close to 1 to 2 years. So this is a place where we have to take notice of this and then treat accordingly. And here the 90% of the bowel adaptation takes place in this phase. So luminal nutrition is very essential for adaptation as well as and should be initiated as early as possible. See, this is important because adaptation starts from 48 hours. So nutrition should be initiated as early as possible, though in stages, very slowly we have to do it. Parental nutrition is also essential throughout this period. So it's not purely enteral, we'll have to give parental also. And after the adaptation phase comes the maintenance phase. Maintenance phase. Here the absorbed capacity of the intestine is as maximum. That after 1 to 2 years later. Now, what are the congenital causes as well as the acquired causes of this short bowel? If we take the pediatric necrotic enterocolitis, intestinal atresia, congenital malformation, intestinal volvulus, these can lead to shortcut. In adult, this is a common condition we see Crohn's disease. This Crohn's disease is one of the functional causes of short bowel syndrome. Radiation enteritis. There's no surgery done, but because of the radiation, the intestine gets damaged and lead to non-functioning of the intestine. And mesenteric vascular accident, here also it's not a total occlusion, but partial occlusion, they lead to absorptive mechanism which is being lost. And in elderly children, we have intussusception, and in adults we have a recurrent intestinal obstruction. So all these are causes for both congenital and acquired. Apart from these congenital neonatal causes, there's a congenital cause of gastroschisis, omphalocele, and meconium peritonitis. Pediatric surgeons will be more seeing all these conditions. Now, the structure, as I tell you, less than 200 centimeters of loss or more than 50% of the viable small bowel is removed. There will be increased risk of this short bowel syndrome, and the predisposing factors are the premorbid length of the bowel. What is the existing remnant of the bowel? So these are the factors which are important for the outcome of the effects of short bowel syndrome. The segment of intestine is lost, that means the jejunum or the ileum or the IC wall or the colon. And age of the patient, here the infants tolerate better because they have a lot of regenerating capacity of the intestine. Children or infants doing resection, they recover faster compared to adults. And the presence of the remaining length of small bowel and colon, as I told you, presence or absence of the IC wall. So we can classify the short bowel syndrome as with a proximal jejunal resection or with a distal ileum resection. So as I told you, the presentation in the definition, I told you about the steatorrhea, diarrhea. So we have a lot of dehydration and electrolyte disturbances, significant weight loss. After resection, patient will lose weight. There will be fatigue, malaise, and lethargy because of nutritional deficiency, malnutrition, mineral deficiency of all these minerals, vitamin deficiency, and macronutrient deficiency. So patient can have recurrent bacterial enteritis because the flora is gone, the immunological system is gone, mucosa is gone. So, and then we'll have stone-related problems, gallstones, renal stones. Gallstones because of the altered bile metabolism, renal stones, I told you about the high oxalate levels. And apart from that, stomach-related complaints of the vomiting, bloating, GERD, gastric ulcerations, failure to thrive. And patients who are taking different medicines for this short bowel, the toxicity of the drug can increase because the pharmacodynamics and pharmacokinetics change in these people because of the altered liver, altered absorption, and altered surface area. So we have to be very careful of this drug toxicity. And the patient can have bowel obstruction, a dynamic of Crohn's disease we are seeing. Suppose if there's direct obstruction because of the continuous ulcers, then that can lead to a real complication in this short bowel syndrome. So then we come to the features of the symptoms occurring because of TPN related issues like line sepsis and fulminant hepatic failure. And enteral feeding relation issues like a gastrostomy or the nasogastric tube issues. Because there's be displacement, there'll be removal, there'll be infection, there'll be all these factors, but the local issues are there. How do you work up a case of short bowel syndrome comes? Apart from the basic hematological, biochemical, then we go for the radiological, microbiological, histopathological, and other investigations. Now, apart from the complete blood count, we still look for anemia, thrombocytosis, thrombocytopenia, and hypersegmented neutrophils. This gives us the general nutrition status of the individual, and then comes to albumin. This is a good indicator for hepatic protein synthesis. It's an indicator for the overall nutrition status. This is very much reduced in all these patients. So this is a good marker. It's very important to serum albumin. So this albumin level estimation also helps us to monitor the nutrient support regimens. Then we have the rise in the liver enzymes because of the TPN-induced liver failure. Electrolyte imbalance can occur during TPN. Blood urine nitrogen, renal reserve is affected. dehydration, and overfit with protein. Now, then comes the vitamin level estimation. All the vitamins will be reduced. The coagulation profile is abnormal because of the deranged liver function. And when I was going through it, I saw some, how the short bowel affects the kidney also. The different mechanisms. So then we go for the electrolytes, creatine, calcium, magnesium, phosphorus, then triglycerides, cholesterol, folate. All these things are done, as a periodical interval, or twice weekly, or weekly, or monthly. Because this judges the treatment part. Then we can go to the radiological, a plain chest X-ray to know the position of the CV line, a plain X-ray abdomen for any suspected bowel obstruction, and after ultrasound we look for the fungal balls in the kidney. One of the complications of TP and short bowel syndrome in the kidney, presence of renal stones and presence of gallstones, liver failure, the ascites, liver text abnormality, portal vein thrombosis, CT abdomen to identify the persistent sepsis, and then sometimes we'll have to do for angiography because if the patient has to undergo a potential for a liver transplant or a bowel intestinal transplantation, then we'll have to go for angiography because ultimately at the medical treatment phase we have to think of a intestinal transplantation. Then microbiological renal blood cultures have to be done from the central and the peripheral sites, urine analysis, blood culture, CV line tip culture, and then the sepsis because the patient will be long term on this IV lines and CV line. So we look for the sepsis. Then gut mucosal atrophy, bacterial translocation, as I told you, both from the colon to the ileum and from the ileum or the remnant small intestine to the system. And then skin flora infection can also happen. Then sometimes rarely we'll have to do a liver biopsy to look for unexplained liver involvement and which is TP and related liver problems. The pathogens is so many. Then the endoscopy may have to be done to see for the presence of peptic ulcer disease and presence of the chronic liver disease also if the patient is having varices and then hypertensive gastropathy. And then we'll have to go for a DEXA scan of the bone because osteoporosis can happen, metabolic bone disease we'll have to look into for the nutritional effect on the bone. This is a very complex part. Now coming to the treatment. So we need a multidisciplinary approach, both medical as well as surgical. I think the surgeons are around in this group now. So medically nutrition, I was telling you both we need enteral and parenteral nutrition. We have to look for dehydration because I told that's one of the factors for making the patient let down, becomes fatigued, patient will gross dehydration. We need electrolyte replacement. We need acid reducing agents, PPI and H2 blockers. Antibiotics for bacterial overgrowth, not only for antibiotic for infection for the this unnecessary bacteria present in the gut also, the bacterial overgrowth. And sometimes because the bile salts are more, we need chelators, and of course psychosocial support is very important. We have to explain the patient what's the condition, why it takes a long time. It's not a what you call immediate effect. So both the nutrition part as well as the psychological part, this support is very important. And surgical care, there's so many non-transplant surgeries apart from the small bowel and the liver transplants. That I'll be just touching upon in the next few slides. So the nutrition, I told you, very important. A patient with a prolonged NPO and then leads to gut mucosal atrophy, bacterial translocation, and then liver sepsis. So that's why early nutrition is important. Early aggressive nutrition is important as soon as the patient can tolerate. Most important stimulus because for this, adaptation. As I told you, intestinal adaptation occurs, so we have to compensate with the nutrition appropriately, not overload. And then, afterwards, gradually, once the enteral nutrition starts, gradually discontinues with the parenteral nutrition. Now, how enteral nutrition is important in such case? This encourages the crypt cells to probably believe this nature is improving the adaptation. So, enteral nutrition will increase the adaptation, right? So now the crypt cells proliferate, leading to an increase in the crypt depth and lengthening of the intestine villi. The nutrient receptors also increase by giving enteral nutrition. Production of trophic intestinal hormone secretions are also improved because there is loss of these trophic intestinal hormones after resection. Production of digestive enzymes. See, loss of the mucosal can reduce, as I told you, reducing the pancreatic and the duodenal enzymes. So this enteral nutrition will increase it, and then also improves the bile flow and preventing cholestasis. Now, some concerns with enteral nutrition. We have to consider the fat intolerance by giving, long chain fatty acids, and carbohydrates parenterally and should be given. And continuous enteral feeds is better than tolerated than bolus feeds. This is one of the factors which can lead to it should be continuous enteral feeds. It's not be given as a bolus. Just we rise to we give every hourly, every 2 hourly. That way of this enteral feeds is not advisable because that leads to diarrhea. And again, the fats are better tolerated than carbohydrates. Carbohydrates are given preferably as a parenterally, whereas fats are given enterally. And whenever the patient has high stool volume or frequency in the treatment process, we should not stop or substantially lower the volume, but we have to alter the concentration. So we generally, with the patient having the loose stools, then we try to stop it. If we alter that, how do you alter it? By decreasing the amount of carbohydrate within the enteral feeds, decreasing the volume and the concentration of feeds, and avoiding fibers. By this, we can take care of this rather than total stopping it. And only we have to reduce the volume only when the patient is having GERD or vomiting. So otherwise, just with this high stool frequency, we have to alter the enteral feeds. So we take care of the carbohydrate, fat, protein. This, I think, TPN is itself a big topic. So here the preference is for monosaccharides, medium chain triglycerides, long chain triglycerides. So all this improves the nutrition and absorption and preventing the diarrhea. So what are the factors predictive of achieving independence from TPN? That is when we can wean off the TPN. How can we know? Depends on the residual bowel length, depends on the colon is intact or not, depends on the IC valve is intact or not, and then the residual small gut, whether it's diseased or healthy. Depends on jejunal resection. Bacterial overgrowth is vital. Dysmotility of the bowel. See, once the bowel is cut, it functions in a haywire fashion. So there's a lot of dysquality. And there's one product, deglutide. This is a GLP-1 analog. It is being tried and is being useful. The enhancement of the restoration of the structural and the functional integrity of the remaining intestine. So the residual intestine gets stimulated by this to function little normal way. So, and then other factors which can predict is serum citrulline level. We have a lot of GLP-1 analogs, but this is not available. I don't know whether this is drug specific or a class effect. If it's a class effect, I think we can try other GLP-1s which are available. Serum citrulline level is very useful in the short bowel. This is alpha amino acids is a key intermediate in the urea cycle. It is the level of citrulline level correlates to the small bowel length and to the net digestive absorption of fat. So by this estimation, we can know the severity of this bowel dissection as well as what's the effect on the digestion of fat. The cutoff value of 20 micromole per liter is classified for short bowel patients. And with permanent intestinal failure, it has a high sensitivity, a high specificity, a positive predictive value, and negative value. So it is a more reliable indicator than anatomical variables to separate transient as opposed to the permanent intestinal failure. So if this is elevated, consider a permanent intestinal failure. It is a surrogate marker for the bowel length and function. So not only for the length as well as function of the remaining bowel length. It's an indicator for allowing the distinction of the transient from the permanent intestinal function. So I told you about this teduglutide. It's a GLP-1 analog. It reduces the need for parenteral support. See, parenteral support is required parenteral nutrition for almost 1 to 2 years. So once you start this medicine, the intestinal failure will recovery faster. So the recovery time for TPN will be reduced. So here it's mentioned that it restores the intestinal structural and functional integrity. And by promoting growth of the mucosa, promoting growth, that's very important. The mucosa is lost. And it also reduces the gastric emptying and secretion. These factors could increase fluid and nutrient absorption in patients with short bowel. And apart from that, we have micronutrients, nutrients replacement also. All these things has to be done on a regular basis after monitoring also. Now, bacterial overgrowth is very, very important in this short bowel. See, I told you the presence of ileocecal valve. If it's absent, this colonic flora will mix up with the small intestinal flora. There's dysmotility of the residual gut. The manifestations are, I told you, deconjugation of the bile salts and depletion of the bile stores by bile salt stores, the vitamin B12 deficiency leads to pernicious anemia, carbohydrate malabsorption, metabolic lactose dehydration. And because of this overgrowth, you may have to give metronidazole, alternating with either kanamycin or oligonucleotide. Probably rifaximin, I don't know, I feel rifaximin can also be added into this. Now, Giving codeine or loperamide, it's not advisable because it can lead to bacterial overgrowth. So we generally, when the patient is having diarrhea, we try to give anti-motility agents. But in this case, this is not the indication. Octreotide is also sometimes used, but because it has an effect on the worsening of the cholestatic liver disease. Glutamine and CCK are other things which are not much effective. Now comes the surgical care. So the diverting ileostomy has to be done sometimes, in case of the malfunctional colon. Colon is not functioning the normal way it should. When the colon is retained but it's not functioning, then we'll have to do ileostomy. Then central venous line insertion. PEG, percutaneous endoscopic gastrostomy, because just like to give the encourage enteric feed. So these are non-transplant surgical methods, and reversal of stoma has to be done. This also, it improves the absorptive capacity of the residual gut. So other methods to see, there's an increase in the transit time of the short bowel by the segmental reversal. That means the residual intestine is there, we cut into pieces, and then the segments are reversed. So instead of going into antegrade fashion, the segment will put as a speed breaker to reduce the transit time. By that, what happens? Absorption can increase. Segmental reversal of small bowel. Interposition of segments of colon between segments of small bowel. That means part of the colon is removed and put between the segments of the small gut. So these are all surgical techniques. And valves are not there in the small bowel. So we create by valves by surgical techniques. And retrograde electrical pacing of the small bowel. I don't know how they do it. And apart from this, how to increase the gut length. This is LILT, longitudinal intestinal lengthening and tailoring. That means suppose the centimeters it's about 20 or 30 centimeters, you increase to 40 to 50 centimeters by this technique. I'll show you the picture. The other one is a step. That's a serial transverse enteroplastic procedure. So this is the way, you increase the absorptive capacity by making it into 2 tubes, the intestine. And then, the step is here. See, this is the bubble which is cut into by the staplers and making dents into this, and then this becomes elongated. So absorbed surface area increases. So this is known as intestine with the stapling device. It's then perpendicular to the long axis of intestine. So this is a step technique. That is enteroplasty. Then this is one of the major topic, intestinal transplantation. This needs a separate talk by itself. I think surgeons can do on this. So it's indications of the life-threatening complications due to intestinal failure or long-term period. How long can the TPN can begin? 1 year, 2 years, but beyond that, complications can occur. So such patients are the candidates for intestinal transplantation. And the patient is having overt liver failure and thrombus of the main central veins because continuous TPN administration. Frequent episodes of catheter-related sepsis, frequent episodes of severe dehydration. So all these are medical level, we lose the patient when they don't go at intestinal transplantation. So these are the indications for the intestinal transplantation. Now, what is in store for the future? See, there's there's a repair and regeneration. This has come in the biomaterials in 2020. Repair and regeneration of small intestine has been tried. So I'll just read out this. To regenerate or to reconstruct, imagine reconstruct in a lab. Due to its complex structure and functions can happen. Recent developments in stem cell research, advancing engineering technologies, and regenerative medicine strategies bring new hope of solving clinical problems of the small intestine. This review has, reviewed the structure, function, development, cell types, and matrix component of the organoids have developed. Intestinal organoids have been developed. That means just like we have humanoid. So these organoids are the artificial organs created in the lab, and then they are putting it back along with tissue engineering. So this is very exciting to know about what is happening in the basic level in the treatment of the short bowel. So thank you. There's a lot more to cover, but still because of the shortage of time.
Yeah. Thank you, Dr. Sudhir. And it was an amazingly awesome presentation. And I just realized how complex and intricate our small intestine do function. And when we don't have it enough, like in the case of short bowel syndrome, it becomes even more complex. So I believe that in the case of short bowel syndrome, it's a multidisciplinary approach where a lot of different doctors have to play a role. Yes. So we would like to take some questions. Questions.
Yeah, yeah. Please carry on.
Yeah.
I'll try to answer that because subject is so vast.
Yeah. Absolutely. So, sir, a lot of time, the patients who are on long-standing TPN, they develop some kind of liver dysfunction and, in fact, liver failure as well. Tell some little more insights about this liver failure associated with TPN, sir.
Yeah. Now, the many mechanisms for this TPN causing liver failure. As I told you, the bile secretion is increased in the bowel. There'll be sort of a fat accumulation in the intestine because of this our TPN, and then the patient can have cholestasis. And apart from the bacterial overgrowth, as I told you, ileocecal valve is damaged. There'll be bacterial overgrowth. This also all these multiple mechanisms are there. 4 or 5 mechanisms are postulated, but which is major one we don't know. But any ultimately can lead to a liver failure. That's why in the follow-up we'll have to look for the signs of liver failure like portal varices and hypertensive gastropathy. And sometimes the intestinal and liver transplant are done both in the simultaneous same patients
Yes.
with the patient on long-term TPN.
Yes, sir. So, in your opinion, like, what is the most common indication of most common reason for short bowel syndrome in India?
See, I divide into two, medical and surgical. And medical, we have seen commonly of the Crohn's disease is one of the thing. Then comes the radiation enteritis. And then, with the surgical part, we see like mesenteric ischemia, the gangrene of the bowel. This is the main cause of and the volvulus is another one. So the volvulus also is in quite a few cases here. So these are the common cause in the surgical side. Now, when it comes to children, the congenital defects are more different. So it depends on the age and depends on the medical and surgical causes.
Right, sir. And in the current COVID pandemic, sir, a lot of people have encountered cases where they have seen portal vein, superior mesenteric artery, or vein thrombosis, and leading to small intestinal gangrene and all. And there are a lot of patients who underwent this resection for them. And any insights about this thing, sir?
Yeah, actually, we had a talk on mesenteric vascular occlusion in one of the when we had the webinar on the COVID, and Dr. Suresh was
Yeah.
talking about the intestinal gangrene.
Yes.
So we have quoted some cases also which they have done as well as in the international literature. Quite a few cases of some intestinal resection have occurred, but the real follow-up I'm not very sure because I've seen COVID causing short bowel. I've not personally seen any case, but generally they'll be behaving the same way.
All right, sir. So, any other question from the eminent faculties present over here?
Yeah,
Yeah,
actually, Dr. Dheeraj,
Yes, sir.
you were telling about the most of the time the patients will be on the TPN, but they will be only in the acute phase, no, sir. Afterwards, there will be adaptation in the intestine, as you said. Then how
Yeah.
come can we stop this TPN later?
See, actually, TPN should start from initial phase itself, acute phase itself. But enteral feeding is one thing which is very important. We start very slow in the first 1 to 3 months. Gradually, the enteric phase will increase, the feeds will improve, and because adaptation starts occurring after 2 to 3 months later. So, but TPN will continue till almost 1 year or so. And gradually that should be wean off once the TPN the adaptation phase is over. So by the time in the 1 year or 2 years, the patient will be quite okay with the enteral feeds. So we start with TPN and enteral feeds in the initial stage itself.
So, absolutely right, sir. So, whether the TPN will be continued for long term or not, it will be decided by the amount of residual small intestine,
Yes.
as well as if the colon is present or not. So, there are several
And
factors.
and IC
Nobody
valve.
wants to take TPN, but it all depends upon the adaptation of the patient.
And we have to note now the presence of or absence of the IC valve. That's another very crucial factor. That's very important because the whole anatomy is altered. The function of the bowel is altered. The IC valve is gone.
Yeah.
sir, very comprehensive and detailed and lovely presentation, sir. Really very, very informative. Just a small doubt, sir. Sir, cancer predisposes because of
But
its
now a few
very
reports have
predisposes
come
to
that
small
those who
bowel
develop
syndrome.
small bowel syndrome are more predisposed to cancer.
So what is the reality of this fact, sir? Because this is on one side it's a double-edged sword. They already have cancer and then they land up with short bowel syndrome because of surgery, and after surgery also they're landing up with increased incidence of cancer, sir.
See, it's as you know, the malignancy is multifactorial. There may be basic genetic tendency, one thing, right? So if the patient is getting treated from one side, other side can still develop. That is one. Second thing is the alteration of microflora. This is very important because there's total alteration. Sometimes the mutagenic microflora can increase. The colonic microflora come into the intestine. Colonic is not a very good microflora. It's a very bad microflora which comes to the intestine. So these are all, mutagenic. So there are so many other factors. I'm not very sure about the other metabolites which are carcinogenic or not, but these are the main things which I feel.
Thank you so much, sir. The
Yes,
microbiome, as you said, has been attributed, but thank you so much, sir. You've very clearly elaborated the facts. Thank you so much, sir.
sir, this gut microbiome is coming in a large way, and there are several papers where it's been implicated either way. So people are doing this bacterial transplantation also, like fecal microbiota transplantation for various conditions, whether it's for liver, whether it's for fatty liver, whether it's repeated hepatic encephalopathy, whether it is severe alcoholic hepatitis, and so on and so forth. Similarly, it's implicated for everything bad that is happening to the patient, or other way as well. Whether it is acute on chronic liver failure, people are saying because of the gut dysbiosis, these all things worsens. So this is a very gray and upcoming area.
Yeah, true. In fact, a couple of years back, and I gave a talk on fecal transplantation in our base forum itself. So we had a lot of other non-GI indications of pancreas, this fecal transplantation, including Parkinson's disease.
Yeah, absolutely.
So imagine the microflora in Parkinson's disease.
In fact, people have said that it's plays even in the role of obesity as well.
Correct.
So if we change their microbiota, they can change their phenotype of the body.
It's one of the treatment for NASH, NAFLD.
Yeah.
So it's upcoming, and as I told you, very expanding, and what do you call it? It is actually my I put it as for every condition I want to give a probiotic, whether it's a diabetes, whether it's obesity, whether it's a fat NASH, whether it's a UC or a Crohn's, you name the condition, I feel like giving it.
But then, sir, which is the ideal probiotic, which will exactly mimic our small intestine, and what quantity and what different strains, that remains enigmatic. And so this is a very empirical approach in my opinion.
Yeah. See, actually the names are very confusing. I can't, because from the oral to the colon, different microflora are there. So
sir,
I just
if I may, with your permission, sir.
Yeah.
Sir, actually, probiotic did come in a very big way, and there was a lot of association with colonic cancer and multiple hepatic SCC and everything. They said everything because of the microbiome. However, the role of probiotics diminished when they found that excess use of probiotics resulted in increase of cancer. So that is why the use of probiotics now, as per the latest recommendations, as per the American and the European recommendations, they are not in favor of using probiotics. Only for short-term use, sir. Only for short-term use.
Absolutely, sir. But then, as far as cancer is concerned,
True.
I feel that it is such a multifactorial thing, and proving association versus causation is very difficult.
Yeah, you're right. As the function of the intestine, small bowel is absorption. You, Dr. Sudhir sir and Mr. Dheeraj sir, they have really made it very absorbing discussion, absorbing presentation. Now my digestion also is going to improve today, listening to your valuable lectures. Kudos.
Thank you everyone.
Thank you, Dr. Sudhir, and thank you, Pace Hospital, for this wonderful opportunity. And then it was really food for thought, and I had this only in my breakfast today. Thank you so much. Have a great day.
Bye.
Thank you, sir. Thank you so much, sir.
Yeah.
Bye, Bye, sir.